Okay. Well, hello, everybody. Welcome again to the ultrasound series. As you probably may or may not have heard, the ultrasound series will continue till about May, and in June we're going to be switching over to the research series. And it looks like we're going to alternate year by year which series we do in this third Wednesday slot. So you'll hear more about that, so stay tuned. Today we have the privilege of having a real expert on fetal neurosonography. Someone who's published many papers on the subject. Anna Monteagudo, who's from NYU. She did her medical school and residency at Einstein, where I also did it. Actually, we probably overlapped by 2 years. I don't know if she knows that. I was there at the same time. And then she did the fellowship at Columbia and has been at NYU for a long time. I don't know how long, but a long time. We don't use years. She's currently professor of obstetrics and gynecology and director of the maternal fetal medicine fellowship there. Without any further ado, please welcome Dr. Monteagudo.
Thank you very much for that kind introduction. And you're right, we don't count the years at this time. So good afternoon and good morning to those of you who are, I guess, in the West Coast. My talk is going to be geared to the MFM fellows, and an MFM fellow is really expected to learn during the fellowship to scan both the normal and the abnormal fetal CNS. Here we have an outline of my lecture, and I'm going to try to go through all these items. So what is unique about the fetal brain? The central nervous system develops slowly and continuously throughout the entire pregnancy. The greatest spurt in cell numbers occurs during the first 20 weeks of the pregnancy. After that, mostly there is increase in size of the brain. CNS anomalies are the most common fetal anomalies, second only to cardiac anomalies. So let me give you some facts about neuroscan. To do a fetal neuroscan, one has to know the CNS embryology and developmental milestones, understand the most frequent CNS anomalies, and use high-frequency, hopefully transvaginal transducers. And lastly, we really need to understand how to use and when to use 3D ultrasound. During the first trimester, especially at the time of the NT scan between 11 to 13 weeks, several structures can be visualized, such as the integrity of the cranium, midline fox, choroid plexus, intracranial translucency, or actually lack of visualization, which has been associated with open neural tube defect. In this slide, we see normal images of fetuses at 11 weeks and 2 days. Here we can see in this fetus that is in a sagittal position the integrity of the cranium. In an axial section, we can visualize the midline fox and the choroid plexus. Some people refer to this particular view as the butterfly appearance of the brain. This is the view that you use to obtain when you're doing your nuchal translucency, and the intracranial translucency is this space that we see here behind the brainstem. Lack of visualization has been associated in some retrospective case series with open neural tube defect. Here we have examples of brain pathology. These two slides represent the exencephaly and anecephaly sequence. In exencephaly, we see that there's absence of the calvaria and the brain is exposed. Later on, as the pregnancy progresses, we see this very odd-shaped head due to the absence of the calvaria. This is a normal picture of a head at a comparable time in gestation for you to compare. In this slide here, we see that there's absence of the midline parts. This is the normal. This is a case of a lower holoprosencephaly. And lastly, I just want to bring your attention to this screen in which we have the absence of the intracranial translucency, which is here in this particular spot. The yellow arrow points to it. During the second trimester, there are guidelines specific to imaging the fetal brain. Both the AIUN and ISWOG have published guidelines. In the AIUN guidelines, as part of the anatomical survey, these are the structures that we must see in order to have a complete study. In addition, there are a couple of biometric measurements. The ISWOG guidelines divide the brain scan into the basic scan, which I'll discuss first, and the neuroscan. The basic scan is performed using transabdominal sonography in the axial plane. And here are the structures that biometric measurements that we must see, and here are the brain structures that we need to look for in order to have a complete brain scan. Let's go over some of the structures that we see. Let's start with the transvertebral plane. In the landmarks that we see are the frontal horns, the cavum septipellucid, the posterior horn. We can see the choroid plexus right here. And take a look at the location of the calipers, which are over the glomus. Let me show you a little bit more detail where we really need to measure the lateral ventricles. The lateral ventricles needs to be measured in the transventricular plane, crossing over the glomus of the choroid plexus, and the calipers need to be in the inner edge of the ventricle. Sometimes we see a separation between the choroid plexus and the wall of the lateral ventricle. Up to 3 millimeters, this measurement is considered to be normal. We all know that the normal size of the lateral ventricle is less than 10 millimeters. So let's go to the transthalamic plane. What we see here, again, the frontal horns, the cavum, the area of the thalami, the hippocampal gyra, and also this is the place that we do our routine biometric measurements of the fetal head. The transcerebellar plane shows us again anteriorly the frontal horns. We have the cavum, the area of the thalami, the cerebellum, the cisterna magna. And please note that the cisterna magna at normal size is less than 10 millimeters. This is also the plane where we measure the transcerebellar diameter. So this is a summary of the planes that we do in the transabdominal axial section. However, if an abnormality is detected during the basic brain scan, a detailed targeted fetal neuroscan is recommended. I prefer to do this scan transvaginal, and I hope that by the end of this talk, you would prefer to do it that way as well. So fetal neurosonogram equals to multiplanar imaging. So in order to be able to do a fetal neuroscan, we have to use additional planes. This scan looks at the brain in greater detail than the basic transabdominal scan in the axial section. Although it can be performed transabdominally, I prefer to do it transvaginally, and the planes that need to be added are the coronal and sagittal planes. In addition, we can add the 3D sonography, and I hope I'll be able to show you some of the advantages of using 3D sonography when we're scanning the fetal brain. So let's look at a slide in which we compare 2D transabdominal sonography versus 2D transvaginal. When we are doing 2D transabdominal ultrasound, our sections are mainly in the axial section, and the sagittal and coronal sections sometimes can be obtained, especially if the fetus is in a bridge presentation. But if the fetus is in a vertex presentation, this may be very hard to obtain. Using transvaginal sonography, we can access the sagittal and coronal sections relatively easy. However, the axial sections may be very difficult to obtain and depend on the lie of the fetus. Please note that when we do transvaginal 2D sonography, all the sections radiate from a single point. The 2D transvaginal scan is a transfontanelle scan. As I mentioned earlier, we can easily obtain the coronal and sagittal planes by just rotating the plane of the probe over the area of the fontanelle. Remember that all brain sections are going to radiate from that single point. As I mentioned earlier, the fetal neuroscan, we are adding additional sections and planes. So these are the structures that we must see in the coronal and sagittal plane in order to be able to adequate image or to perform a fetal neuroscan. So let's go over. There is a multitude of coronal and sagittal sections that we can obtain. However, if we concentrate in these 4 sections, we can see all the anatomy that we need. Let's first look at the anatomy of these 4 coronal sections. In this very anterior coronal section, or what we call frontal 2, and other authors refer to as the transfrontal plane, we're able to see the interhemispheric fissure, the brain parenchyma, in addition to the orbit and the sphenoid bone. Moving slightly posterior, we can see the choroid nucleus, the genu of the corpus callosum, the cavum septipellucid, as well as the frontal horns. Again, moving a little further posterior, we're right here, more or less, we can see the thalamus, the intraventricular foramen, which is not depicted in this particular picture. In this picture, what we see is the atrium of the lateral ventricle. And moving now, let's zoom in the mid-corona. And the reason that I want to zoom in this mid-coronal plane is because it allows visualization of the leaves of the septipellucid. These are the lateral leaves of the septipellucid, and this is the cavum septipellucid. This is very important to visualize in order to be able to diagnose a genesis of the septipellucid. Now, we are on our very last coronal section, which is a pretty posterior section. In this section, what we see are the occipital horns that look very round. Again, the area of the interhemispheric fissure, the cerebellar hemisphere, and in the center, we see the brightly echogenic vermis. The vermis is always very brightly echogenic in comparison to the rest of the brain. Now let's start looking at our sagittal and coronal section. There are 2 main sections that we look, which is the median and the parasagittal section. So let's look at the anatomy that we see in the median section. Right smack in the center, we see the corpus callosum. Below it, we have the cavum septipellucid. We have the area of the brain stem and the pons, the area of the posterior fossa, and in this area, the most brightly echogenic structure is the vermis, and this triangular structure is the 4th ventricle. Let's zoom in now into the corpus callosum, and let's look at the different parts of the corpus callosum. Here we have the rostrum, or the anterior part, the genu, corpus and splenium. Why is this important? It's because the corpus callosum forms in an anterior to posterior fashion, and there are certain conditions, especially that are going to destroy the posterior part of the corpus callosum, and it's going to result in partial agenesis of the corpus callosum. The cavum septic pellucidum connects to the posterior aspect, which sometimes is called the cavum virgi. These do not connect to the ventricular system. And using color, we can visualize the pericallosal artery that is located right over the corpus callosum. In this median plane, we can see the changes that we see throughout gestation. At 16 weeks, there is no gyri on the cell side. The brain looks pretty smooth, and we're unable to visualize the corpus callosum and the cavum. By 22 weeks gestation, we can see clearly the corpus callosum, the cavum, of course, posteriorly we see the vernus and the fourth ventricle. And by 34 weeks, not only are we going to see the corpus callosum, but we see this pattern of lines that are brightly echogenic. These are the gyri and the soul side. Note that at this time, the cavum septic pellucidum is no longer apparent because it has begun to close, which is a normal developmental event. Now, let's turn our attention to the last section that we imaged where we scan in the sagittal plane. This is a parasagittal or an oblique one. So what are the structures that we see? We usually see the entire lateral ventricle. Anteriorly, we see the frontal horns. Posteriorly, of course, the posterior horns, and then we have the inferior horns. We see the thalamus and the choroid plexus. I'm not sure if you can see the choroid plexus here. And this here is the cortex of the brain in this particular fetus. So now we have completed our basic scan using 2D transabdominal sonography. So let's turn our attention to the 3D. So why do we want or why do we need to use 3D of the brain? This is to better define the anatomy seen by 2D, to perform sonographic evaluations that are not available with the conventional 2D scans, such as 3D reconstructions, serial sections, inversion, 3D angiosonography, etc., and to use as an additional tool for counseling patients and communicating with other specialties such as neonatology, neurology, neurosurgery, radiology, genetics, etc., to reassure patients with a normal fetus. This is very important. If a patient in the prior pregnancy had a fetus with a brain anomaly, being reassured that everything is normal is very, very important. And lastly, to store digital volumes for future studies and for teaching fellows and residents. Also, obtaining a volume of the fetal brain, it can be done transabdominal or transvaginal, is relatively fast and easy and diagnostically valuable. If the brain anomaly is seen, 3D can be helpful to localize, define, and assess the extent of the lesion, and the results are better than using 2D ultrasound alone. And I have to say that in experienced hands, 3D can be comparable to MRI, and early in pregnancy, it may be better than MRI. So what are some of more advantages of the 3D? Is a bedside or offline analysis, off-site expert consultation. You can save the volume and mail it to a friend across the United States for a consultation. Data is easily revisited for additional evaluation. Short process time is an effective tool because it simulates real-time scanning. So you can take a volume of a patient that was done in your practice, in your office, and you can take it to your office and go over and over again. And lastly, it's a quick way to image the median plane, especially the corpus callosum and the vermis. So here are some of the goals of what I'm going to try to show you about 3D ultrasound of the brain. So first, let's start with volume acquisition. So what is the basics of a volume acquisition? Well, in order to get a good volume, you have to start with a good 3D study. The secret of any good 3D study is a very good 2D study. Next, acquisition should attempt to overcome some of the inherent limitations of 3D ultrasound. Namely, if there is an acoustic shadowing in the acquisition plane, it will be embedded in the volume. If fetal movements are present during the acquisition, the result is motion artifacts. If surface rendering is desired, a fluid tissue interface is needed. Other factors such as fetal position, maternal obesity may challenge 3D imaging the same way that it challenges 2D sonography. When we're doing a transabdominal acquisition, the volume is acquired through the acoustic window of the sphenoid bone and the squamosal suture. Shorten acquisition time to minimize artifact. Many times I have the patient hold her breath and try to do a very quick volume so you don't have all that motion embedded in your volume. So once we acquire a transabdominal volume, this is going to be the display that you're going to see on the screen of the ultrasound machine. Box A always displays the plane of acquisition, and in this particular example, I acquire my plane at the level of the BPD. Box C is a reconstructed plane, and in this case, this is going to be my median section of the plane. Transvaginal acquisition, with transvaginal sonography, the volume is acquired either in a sagittal plane, as you can see here, and when we acquire in a sagittal plane, the reconstructed plane is the axial one, or you can acquire the plane as here in a coronal section of the brain. When we do transvaginal acquisition of a 3D volume, the volume is going to be acquired through the acoustic window of the anterior fontanelle. Sometimes we use the metopic suture or the sagittal suture, and here you can see where they're located. Any of these sutures are going to help in the acquiring a very nice clear volume. To access the anterior fontanelle, we have to align the transducer with the fontanelle. Sometimes we have to manipulate the fetal head through the abdomen with our hand. Once you're able to access the anterior fontanelle, by rotating the probe 90 degrees, you can go between the sagittal and the coronal plane. And here's just another example showing the same thing. Here is my abdominal hand holding the fetal head and my vaginal probe. We're trying to locate the fontanelle. And in our screen, this is what we're going to do. We're going to move from the side to the area of the fontanelle. So once we acquire the volume in the vaginal, using transvaginal sonography, here we acquire the volume in the sagittal plane. So box A always is going to display the plane of acquisition regardless of the position of the fetal head. So I like to always acquire in the sagittal plane. Many times, even if the fetus is looking towards the right side of the screen, I just rotate the fetus to look at the left. This is the way I do it, and helps me orient myself. So in summary, let's compare 3D transabdominal sonography and how we acquire a volume to the transvaginal. In transabdominal 3D, the volume is acquired in the axial plane. The sagittal plane is a reconstructed one. Near field, this is the near field, may be blurred due to bone attenuation. When we obtain the volume transvaginally, the acquisition is done either in the coronal and sagittal plane. Our axial plane is the reconstructed plane. Usually we have excellent resolution in the median plane or in the median aspect. But as we move laterally towards the skull bones, the resolution decreases. So now let me show you some of the manipulations that you can do with the volume. The first thing that I like to do is to zoom the volume so the picture occupies almost the entire box. So first we zoom, then we can change the chroma mapping. The chroma mapping, some people believe that it's a gimmick, but at times it may emphasize different structures. I like to play with all of them when I'm scanning the brain. The marker dot, here, this particular structure here, orients you in all three planes. It represents the same exact place in all three planes. So here's the marker dot, here and here. Let me just show you a little bit more where it is. And usually I like to place the marker dot in the cavum septipellucidum or between the thalami. This helps me orient myself where I am. We can also do manipulations such as rotation. Here in box A, we have the axial section. I usually like to have in box B the sagittal section, so we can use the controls of the ultrasound machine, the X, Y, and Z control to perform rotations. And we can put our axial section or sagittal section or the section that we desire in the box that we like. I like to put in box B the sagittal section. So the goal of rotation of the image is to better orient the observer. So you need to do it the way that you will feel more comfortable. So let me show you some of the display modalities that we have. Here is an example. This is the volume, and these are all the display modalities available. I'm not going to show you all of them. Let me just show you the ones that I use in a regular basis and that I think are important for you to learn. So the first one is the orthogonal planes. This is the section that we see immediately. This is a case of a fetus that has hydrocephaly as a result of an intracranial hemorrhage. So all three planes are seen simultaneously. We have here the coronal, the sagittal, and the axial, and we can see the dilatation of the lateral ventricle, the thin choroid plexus, and small areas of blood clots. So this is very useful to be able to localize pathology. We can also use something called the thick slide, and what we do in thick slides is the software, as you see over here, is going to collapse a pre-selected number of successive slides. In this particular example, they are enclosed within this box and display the render image. This helps enhance edge detection. So you can see here the dilatation of the lateral ventricle very clear, the choroid plexus. The next is the tomography, and we can do serial sections. This is an example of serial coronal sections. This tomography is similar to what you would see when you do a CT or an MRI. So in this particular patient that has hydrocephaly due to an intracranial hemorrhage, I'm obtaining coronal sections from anterior to posterior at 3 millimeter interval, so we can see the anterior horns, we see the cable, we keep on moving posteriorly, and eventually we come here to this section where we see the interventricular foramina that connects to the third ventricle. We continue to see the dilated third ventricle, the massa intermedia. So this is very helpful. And in this posterior section, we can see that there is also dilatation of the posterior horns. And this is a little bit of blood clots in that ventricle. These are serial axial sections coming from the top of the head down. Here is superior to the area of the lateral ventricle, so you can see the dilatation of the lateral ventricle. These are small areas of hemorrhage, blood clots. As we move inferiorly, we see that the lateral ventricles are dilated, the choroid plexus is dangling, and the third ventricle is dilated, and the interventricular foramina we can clearly see connecting to the anterior horns of the lateral ventricle. We can do inversion, and inversion is something that I really like to do, and it gives me a lot of information. In inversion, what happens is the selected area, which in this particular case is the lateral ventricle, the fluid fill of the lateral ventricles of the acquired value can be inverted, which means areas that were black before, we're going to give it some color. So now these are echogenic. So this is the shape of the lateral ventricle here. This is the dilated third ventricle. And the little black hole that you see here represents the area of the massa intermedia, which is it communicates between the right and the left hemisphere. This is another example of inversion. This is the area that I inverted, and this is what it looks like. And here you can see in this other example of a different figures with hydrocephaly, the dilated lateral ventricles. And lastly, let me show you some pretty pictures of lateral ventricles using the inversion mode. Here in this parasagittal section, we can see the anterior horn, the posterior horn, and the inferior horn. Remember, we don't see the brain. This is just the fluid-filled lateral ventricles. Looking at the brain from the coronal, we're able to visualize the third ventricle. And here, looking at it kind of like an oblique axial section, we see again the third ventricle. This mode is useful in imaging fluid-filled structures such as the ventricular system, and we can see the ventricles in all three planes or sections. Here is an example of a fetus with agenesis of the corpus callosum. In this particular picture, in the orthogonal planes, we have the coronal, sagittal, and axial. We can see everything that we need in order to make the diagnosis of agenesis of the corpus callosum. The direct signs we can see here in the sagittal, which is the missing corpus callosum and cavum septi pellucid. The indirect signs, such as colpocephaly, can be appreciated right here. There's a dilatation of the lateral ventricle. The anterior horns are parallel and widely spaced. And in the coronal section, we can see the interhemispheric fissure coming all the way down and meeting the third ventricle. So using this particular display, we can make the diagnosis of agenesis of the corpus callosum. We can also do a volume in a power Doppler. So if you apply power Doppler, you can do a volume, and what the result is 3D color angiogram. What it does is enable selected images of the blood flow. So here's an example of a normal fetus, normal corpus callosum, and superior to the pericallosal artery. This is the 3D color angiogram of the patient that I showed you earlier. This is the pericallosal artery. It just seems to end, it's foreshortened, it's not present. There is no corpus callosum. Another example of the same patient. Now we're using the tomography, and we have serial sections of the same patient with the agenesis of the corpus callosum. We're interrogating the area of the midline slightly from the left side to the right side and cutting in the middle. We are sure that there is absolutely no corpus callosum cavum septum. And lastly, what I like to do is display the volume using power Doppler plus tomography. So I like to do my serial sagittal sections, and again, we see that the pericallosal artery that should be here is not present. So this is a case of agenesis of the corpus callosum that was seen with 3D. So let me give you another example of another pathology. In this particular case, we have absence of the cavum septic pellucidum. Actually, we have absence of the little leaves of the cavum septic. You remember that I showed you earlier this picture in which we have the cavum, and these are the little leaves, the boundaries of the cavum septic pellucidum. In this particular case, the anterior horns freely communicate with each other. Here we have, in this axial section, we have this box-like appearance. But please look that if you only do a median sagittal section, you're going to have a normal appearing corpus callosum and what it looks like a normal appearing cavum septic pellucidum. So in order to make the diagnosis of absence of the septic pellucidum, this was a case of septic optic dysplasia. You need your coronal section. Here we see tomographic sections of the same patient. We have the sagittal and we have serial coronal section, again demonstrating the absence of the cavum septic pellucidum. Here is another example of the patient looking at it in axial section from the top to the bottom. We have this box-like appearance in the center. The ventricles are communicating with each other. And this is another look at the thick slice. Here we have collapsed this area, and this is the display that we have of this axial section. Remember that the thick slide, what it does enhances the edge detection, so we can clearly see this very abnormal shape in this particular patient. The lateral ventricles freely communicate with each other. This is another example of a patient that has a posterior cephalocele. Here again we have the orthogonal planes, and this is the 3D reconstruction. I think you're very familiar with this particular pictures. We see back here the posterior cephalocele. Using these 3D reconstructions, they are very useful in order for us to speak to the patient and to explain to the patient what is going on. In addition, you can look at the hands, the profile, the rest of the fetus. Here in this particular case, I did serial sagittal sections because I wanted to see if I could find the area of the skull defect through which the brain was herniating into the cephalocele sac. So I think I found the area, and it's right here. Right here you can see that there's some brain going into that cephalocele sac. These are again serial sagittal sections. And here are serial axial sections. Again, I wanted to demonstrate, as you can see here, the skull defect. Here's the little opening, and there's brain tissue going into that. So this patient had a posterior cephalocele. She did not have any other finding. So this is probably just didn't seem to be a syndromic cephalocele. So let me give you at this point some 3D helpful hints. Always start with a good quality 2D image. Transabdominal acquisition is always done in the BPD plane. Transvaginal acquisition can be done in the median or coronal plane. And I did not talk too much about your angle of acquisition or how open we have to make the box. But the bottom line is, when you put the little box to acquire the volume, make sure that the head fills the entire box. After the volume is acquired, save the volume. You may want to zoom the images as large as possible so you can see clearly the pathology that you're interested. Consider using chroma mapping. The marker dot, I like to put it in the cavum septi pellucidi or between the thalami. This helps me orient myself in all three planes. You may want to rotate the plane as desired, as you want it or as you need it. And lastly, you want to use different display modalities to help you enhance or facilitate the diagnosis of the structure you're looking. Sometimes you're not sure if there is a small skull defect, so you want to do, like I show you, serial coronal and sagittal section. And the sections I show to you, the tomographic sections, the inversion, fixed light, 3D angio, etc. So, in conclusion, when you're evaluating the fetal brain, first we're going to start with a transabdominal scanning in the axial plane. And we're going to do the basic anatomy and biometry. And if everything is fine, you are done with the study. You don't need to do anything. If you see a malformation or the patient had a history of a prior child with a fetal brain anomaly, you want to go on and do a neuroscan. In a neuroscan, you're going to add to the axial plane, you're going to add the coronal and sagittal planes. The reason you want to get the coronal planes is because you want to have the visualization of the leaves of the cavum septi pellucid. You want to see all the things, but I think this is critical. And in the median section, you want to see the midbrain, namely the corpus callosum, and posteriorly, you want to see the vermis of the cerebellum. 3D is a useful complement of the 2D targeted scan. And I'd like to thank you for your attention. Thank you very much.
Thanks for that great